Picture two people, both 65 years old, same weight, eating roughly the same, sleeping roughly the same. But one of them has had pain in their knees and hands for 10 years. That pain that shows up when you get out of bed in the morning, improves a little with movement, and never fully goes away. The other one has no pain. Which one do you think has a higher risk of having a heart attack in the next 5 years? Most people would say they're equal. The data says they're not. The data says the one with chronic joint pain has double the cardiovascular risk. Double. And almost no doctor is connecting those two dots in a regular appointment. Before we get into it, I want you to think about something personal. Do you have joint pain? In your knees, hips, hands, shoulders? That pain you've already normalized because you've had it for years and your doctor told you it's arthritis, it's normal for your age? If the answer is yes, this video is urgent for you. Not because the pain is the most important thing, but because what that pain indicates about the state of your cardiovascular system is something nobody has explained to you clearly. We live in a very compartmentalized medicine. The rheumatologist sees the joints. The cardiologist sees the heart. The general practitioner coordinates between the two. But in that compartmentalization, connections get lost that are fundamental. And the connection between joint inflammation and cardiovascular health is one of the most important and one of the least discussed. Rheumatoid arthritis, osteoarthritis, gout, they all have something in common that goes far beyond the joints. They all produce systemic inflammation, and that systemic inflammation doesn't stay in the joints. It travels, it goes into the bloodstream, it reaches the arteries, and it does to the arteries exactly what it does to the joints. It inflames them, damages them, hardens them. Today I'm going to explain the science behind that connection with real studies, without exaggeration, and with concrete things you can do to break that cycle. Most people think arthritis is a cartilage problem, and yes, cartilage is involved. It's that layer of tissue covering the ends of bones that allows joints to move without friction. When cartilage wears down, bones rub against each other, and that hurts. That's osteoarthritis in its simplest form. But arthritis isn't just mechanical, it's also, and above all, inflammatory. And here's the part that changes everything. When there's damage in a joint, from wear and tear, an old injury, excess weight, whatever, the immune system sends inflammatory cells to the area to try to repair the damage. Those cells produce molecules called cytokines, signaling proteins that coordinate the inflammatory response. The most relevant cytokines in arthritis are IL-6, TNF-alpha, and IL-1 beta. Technical names, but what they do is very concrete. They keep the inflammatory state active in the joint. The problem is those cytokines don't stay in the joint. They filter into the bloodstream. And when they reach the coronary arteries, the ones that supply the heart, they do exactly the same thing they do in the joint. They inflame the tissue. They damage the endothelium, that inner layer of the arteries that is the first line of defense against atherosclerosis. And they accelerate the formation of cholesterol plaques on the arterial walls. A study published in the European Heart Journal in 2022 followed more than 18,000 patients with rheumatoid arthritis for 8 years and found they had a 58% higher risk of myocardial infarction than the general population, even after controlling for traditional risk factors like cholesterol, blood pressure, smoking, and diabetes. 58%, without cholesterol being the culprit, without blood pressure being the culprit. Joint inflammation alone was enough to trigger that risk. And here's something I find even more important. That doesn't apply only to rheumatoid arthritis. Osteoarthritis, the common arthritis, the wear and tear kind, the one most people have and normalize, also produces systemic inflammation. Not at the same level as rheumatoid, but enough. A meta-analysis published in Arthritis and Rheumatology in 2023 found that patients with knee or hip osteoarthritis had a 24% higher cardiovascular risk than people without arthritis of the same age and with the same traditional risk factors, 24% higher risk with normal arthritis. the one your doctor told you was inevitable. I want this to be very clear because it's the center of everything we're going to talk about today. The heart doesn't fail overnight. The heart attack, that dramatic event people see on television with the actor clutching their chest and falling to the floor, is the end of a process that takes years, often decades, building in silence. That process is called atherosclerosis, the accumulation of plaques of fat, cholesterol, calcium, and inflammatory tissue on the walls of the arteries. And atherosclerosis is not just a high cholesterol problem, it's fundamentally an inflammatory problem. Plaques don't form in healthy arteries. They form in arteries with damaged endothelium. And what damages the endothelium, besides oxidized cholesterol and hypertension, is chronic systemic inflammation, exactly the kind arthritis produces. The inflammatory cytokines that filter from the joints into the bloodstream do three very specific things in the arteries. First, they activate endothelial cells and make them more permeable, basically opening small cracks in the arterial wall where oxidized LDL molecules can sneak through. Second, they attract macrophages, immune system cells, that fill up with oxidized cholesterol and form what are called foam cells, which are the core of atherosclerotic plaques. Third, they stimulate the production of more collagen and fibrous tissue around those plaques, making them harder and more prone to rupturing. And when a plaque ruptures, a clot forms, and that clot can completely block a coronary artery. That's a heart attack, all of that process accelerated by the inflammation that started in your knees. There's another mechanism I can't leave out because it's both fascinating and alarming. Severe arthritis, especially rheumatoid but also advanced osteoarthritis, chronically activates the sympathetic nervous system. The sympathetic nervous system is the one that controls the fight or flight response. When it stays active in a sustained way, as happens with chronic pain, it raises heart rate, elevates blood pressure, and increases the tendency of the blood to clot. Three major cardiovascular risk factors, all activated by the joint pain you've been normalizing for years. The most dangerous thing about this connection is that the symptoms develop in parallel without anyone relating them. Do you have joint pain in the mornings that lasts more than 30 minutes before the joints loosen up? That prolonged morning stiffness, more than half an hour, is a classic marker of active joint inflammation, not just mechanical wear. And when there's active joint inflammation, there are cytokines circulating in the blood. That's the moment to ask for a complete cardiovascular evaluation, not just an anti-inflammatory. Do your blood tests show elevated CRP, C-reactive protein? CRP is the most widely used marker of systemic inflammation in medicine. When it's elevated in a person with arthritis, it's not just a sign of joint inflammation, it's also an independent predictor of cardiovascular risk. An elevated CRP in an arthritic patient should trigger a conversation about heart health. It rarely does. Do you have swelling in your joints that appears and disappears, especially in the fingers, wrists, or ankles? That intermittent swelling is active inflammation. And every episode of active inflammation is an episode of cytokines circulating in the blood and reaching the arteries. Do you get more tired than normal with moderate physical effort, climbing stairs, walking fast, and also have chronic joint pain? The combination of these two symptoms in a person over 50 deserves a cardiac evaluation, not just a rheumatological one. The heart and the joints are speaking the same inflammatory language, and they need to be listened to together. Do you take non-steroidal anti-inflammatory drugs, ibuprofen, naproxen, diclofenac, regularly for joint pain? This is especially important. Those medications relieve joint pain and inflammation, but they have a cardiovascular side effect many patients don't know about. They raise blood pressure, increase sodium retention, and in some cases raise the risk of cardiovascular events. The medication you're taking for pain may be adding risk to the heart. That's a conversation you need to have with your doctor. Everything we've talked about has a very clear practical implication. If you reduce joint inflammation, you also reduce cardiovascular risk. It's the same fire. Put one out, you put out the other. Omega-3 is where I always start with my patients who have arthritis and cardiovascular risk factors because it's the only nutrient with solid evidence on both fronts at the same time. EPA and DHA, the fatty acids in oily fish, reduce the production of inflammatory cytokines in the joints and simultaneously reduce triglycerides, improve endothelial function, and decrease platelet aggregation. A study published in Annals of the Rheumatic Diseases in 2021 found that omega-3 supplementation in patients with rheumatoid arthritis reduced joint inflammation markers by 38% and cardiovascular risk markers by 22% at the same time. Two problems, one nutrient. Where do you find it? Salmon, sardines, mackerel, anchovies, 2 or 3 portions a week. If you can't or won't eat fish, krill oil has superior bioavailability to conventional fish oil, according to the most recent studies. Water exercise is the second, and I prescribe this with conviction because the evidence is compelling. Swimming and exercises in warm water reduce the mechanical load on the joints while keeping active movement going. And active movement is fundamental because joints have no blood vessels of their own. They get their nutrition by diffusion from synovial fluid, which only circulates well when the joint moves. A still joint deteriorates faster. Plus, water exercise improves cardiovascular function without the impact that land exercise imposes on already damaged joints. 20 minutes 3 times a week in a warm pool, not cold, warm, is one of the interventions with the best evidence for simultaneous arthritis and cardiovascular health. Curcumin is the third, with one important nuance I want to give you. Turmeric powder added to food has real but modest anti-inflammatory effects because curcumin, its active compound, absorbs very poorly on its own. To have a therapeutic effect, it needs to be combined with piperine, the active compound in black pepper, which increases its absorption by up to 2,000%. Yes, 2,000. A pinch of black pepper with your turmeric isn't a culinary quirk, it's basic pharmacology. A study published in Phytotherapy Research in 2022 found that curcumin with piperine reduced joint inflammation markers comparably to low doses of ibuprofen without the cardiovascular side effects. Sleep is the fourth, and I know we've mentioned it in other videos, but in this context the reason is different. During deep sleep, the body produces growth hormone and cortisol drops to its lowest levels. That's the moment when joints repair the damage accumulated during the day. When sleep is insufficient or fragmented, that repair process gets interrupted, joint inflammation increases, cytokines rise, and the heart pays the price. 7 to 9 hours of sleep is not a luxury for someone with arthritis. It's part of the treatment. And I'll close with something that seems obvious, but that most of my arthritic patients avoid out of fear of pain. Movement, not intense exercise. Gentle, regular, consistent movement. Walking, swimming, a stationary bike, gentle yoga. Whatever keeps the joints mobile without overloading them, because a still joint produces more inflammation, not less. Total rest worsens arthritis, and worsening arthritis worsens the heart. Movement is the only medication that treats both at the same time without a prescription and without side effects. Let me go back to the two people from the beginning. Both 65 years old. Both eating the same, sleeping the same, weighing the same. But one of them, the one who's had joint pain for 10 years without truly addressing it, has double the heart attack risk, not because their heart is sick, but because there's an inflammatory fire that nobody put out, that nobody connected to the heart, that nobody treated as the cardiovascular emergency it actually is. I want you to leave this video with one thing very clear. Joint pain after 50 is not just a quality of life problem. It's a cardiovascular warning signal. And treating it properly, with omega-3, with movement, with sleep, with curcumin, with the right medical evaluation, doesn't just take away the pain, it's protecting your heart at the same time. That's what I find most powerful about this connection, that when you take care of your joints, you take care of your heart, that they're not two separate problems requiring two doctors and two different treatments. They're the same fire, and it's put out the same way. Chronic inflammation doesn't distinguish between organs. When you let it burn in the joints, it's also burning in the arteries. And the only way to protect the heart is to put out the fire from where it starts. Share this with someone who's been living with joint pain for years and accepted it as inevitable. It may be the most important information they receive today. And tell me in the comments, do you have chronic joint pain, and have you had your heart checked in the past year? Drop it below. Subscribe if you want more content like this. Take care of yourself.